Yep.
All right, very good. Here we go.
Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Ian. How you doing, Ian?
Good. How you doing, Dennis?
I'm doing well. Today, I'd like to talk about disposition. Essentially every podcast that we've done, it's always escalating care, getting them to a higher level of care, providing ICU level care out in the field. What we haven't gone over is what do we do if we can't evac them and we actually have to go back to our normal job. So how do we, in a smart way, either laterally transfer them or kind of send them back to their family to do the nursing care and the other things.
Yeah, sounds always like the conundrum,
right?
And the approach isn't really that different than what we do in the emergency room or the emergency setting. So, whatever setting them in, the first thing that we're always going to do is evaluate the life threats. Make sure that there's not a life threat present. Somebody comes with chest pain, you're always make sure it's not an MI, unstable angina, PE, all those kind of things. So rule out the life threats, then stabilize whatever's going on with the patient. If they have an infection, do they need some hydration to normalize their vital signs? Do they need medication to treat them and stabilize them? Once they're stable and you feel like they've been stable for a appropriate period of time, which is going to depend on what's going on with them, then the next question is there something that putting them in continuous medical care their condition is going to require, is going to improve their condition? So, for emergency setting, that's always, do they need to be hospitalized? Is there going to be some benefit to that? If there's not, then the next question is this something that they themselves can take care of, or they have family that can take care of at home? And do they have the appropriate knowledge, supplies that they need to be able to take care of at home? I mean, obviously there's a lot of more minor things, a lot of minor, moderate infections that we send home all the time. Once we know we can start them on the appropriate treatment, and they've got somebody there to take care of them and manage them. And then do they have someplace they can go to make sure that they're not getting worse and they continue to get better, whether that's something local, or are they coming back to us at some point for that?
Yeah, I guess when it comes down to, do they need continued care? I guess where is your criteria as far as, they need to go, I don't know, to like a convalescent type home or facility, or just somewhere where there's a medical person that can be in the near vicinity of them, or he can go home with like their family, and I can teach them how to do these basic things.
Yeah, and that's that certainly is going to depend on what they've come in for. But for example, for a lot of infections we see, pneumonia in a healthy person, their vital signs have stabilized. They're able to take oral medications. They're able to eat and hydrate. Then that's somebody that probably really doesn't need to be hospitalized anywhere. We can send them home with appropriate antibiotics, as long as there's somebody that can keep an eye on them and make sure they're not getting worse, and then have some way of them either seeking some help within their medical system, depending where they are, or setting up a time for them to come back and check back with us, in 48, 72 hours, something like that. And then certainly with any condition, it's going to be giving them the warnings of what to look for right? So if someone's getting pneumonia, are they having increasing shortness of breath? Are they getting altered? Are they vomiting, not able to keep anything down? For a lot of the wound care stuff that we see, the question is, are the caregivers going to be able to provide the wound care that's needed? Are they going to be able to do dressing changes? Is that something that we need to teach them before we discharge? Do they have a way of accessing the materials that they need for appropriate wound care? Do we need to teach them about signs of infection, what to look for? Because we need to warn them the things that we're concerned about when we discharge them.
So I would imagine, if they're requiring, let's say they're requiring IV fluids or IV whatever, that kind of precludes them from going back home. That would say, okay, you need an actual medical person that can troubleshoot this and make sure that this is going to continue before either I or they release you home. I would imagine that's probably a good indicator of where they need to go.
Yeah, so certainly for almost everybody, I'm getting them to a point where, or I feel they're at a point where they don't need anything intravenously. Their vitals in most cases have been stabilized for a number of hours, or any abnormal vitals are explained. Certainly if somebody has a pneumonia or an infection, right? I expect them to have a fever. I don't expect that to go away before I can send them out on oral antibiotics. But we have stabilized their vital signs. And something like, the IV, a lot of times maybe somebody needs a little bit of IV hydration up front, but then we can treat them with some Zofran, something else, and we can get them to the point where they can take orals. So maybe we're going to have to do kind of a number of hours of care in between. But once we get to that point where they are stabilized and they are able to hydrate themselves, eat, take orals, then that's the point that I would think about discharging them, and likely would discharge them. But yeah, well, if they're still needing IV resuscitation, then that's a really tricky one to send out. That's going to be much more of a lateral transfer. So can I send them someplace where that can continue? And outside of the first world setting, that's going to be, what does their medical system provide, and can we get them into their medical system for that? Right.
And I mean, and that information is going to come from just what information you've gathered from being in the area. What is the capability of the local clinic? Things like that. Hopefully, if you're treating locals, you've gotten to know other locals, so you can kind of judge on the, their ability to learn, your ability to teach them. But patient education, or educating wherever they're going to go to, how do you organize that? Because we can have some pretty complex patients. How do you organize it to make sure that you don't miss anything?
So for that, it's going to be, you've developed your problem list with the patient you've seen. Typically it's going to be that primary condition you're seeing them for, but that may encompass a number of things. So if it's a wound, for example, are they, what are they going to need for pain control? Are they going to need ongoing antibiotics for some period of time? Are they going to need dressing changes? And I think it's the patient, but even more whoever's helping to provide the care for them, just as much. Do they know how to do these things? So I'm probably going to have to teach them, or have somebody else with us teach them how to do those things. And it'll be drawing up that whole problem list for whatever condition they have, and going through it a step at a time, and instructing them in each of those things as required.
Right. And definitely making sure at least some kind of talk back, or have them demonstrate back that they're not just nodding yes to everything I'm saying, that they can actually do these things, right?
Right. Picking up the medication, explain what this is for, when do you give it, all of the tactile skills, you would have them demonstrate those. So the dressing change, the wound change, describe back to you what an infection would look like. But yeah, so it's closed loop communication, which is even harder if you're not necessarily speaking the same language.
Right. And definitely, I would imagine anyway, before you're making a big decision like this, you're probably going to want to reach out to another provider, telemedicine, or your local doc there that you're working for, as far as some, have them go over your plan. What do you think?
Oh yeah, definitely. I mean, this is always a time for a phone a friend. Most of these decisions, honestly come from your clinical experience, and there are some things that are very obvious to everybody, and they're pretty easy. There's a lot of things that you may not have much experience with. I mean, there's things that I don't have that much experience with, and when I have any question at all, or I'm looking for guidance as to when it's appropriate, then I consult and reach out for a friend. So this is a time where I would always reach out to someone with experience in that condition, or at least a lot more clinical experience than you have, because that's going to help. That's going to help mold your decision and help you learn for the future as well.
Right. And just like with any, good plan, you have to plan if something goes wrong. So I would imagine you're going to have a plan, just like your wake-up criteria. When you're doing a PFC scenario, you would essentially have that same type of criteria of like a return criteria if things go bad.
Yep. So that'll be part of the instruction of things to look for. Although in general, in the emergency medicine side, we pretty much always try and set up something in 24 to 72 hours, depending on what the condition is. But we'll usually have both. So we'll basically have a pre-planned follow-up for evaluation of improvement, as well as instruction in the things to look for that you'd want to come back for much sooner. And then also part of that's going to be, building in is that they have to come back to me, or is there something local or someplace local that I can send them to for that?
Yep. So, I mean, I think talking about it, going over some basics is good. But I think in order to kind of to settle this information, I think we need to go over a couple of scenarios. So I think the first scenario, will be fairly easy. Let's say we have a middle-aged male. He comes in with a GSW to the extremity. There is no bony involvement. We have gotten hemorrhage under control. We've given him some blood. His vital signs have stabilized, and now we have to kind of get back to this military thing. So, what would affect my decision to let him go or keep him?
So the throwing in the blood makes it a little bit more complicated, because the question is, why do we have to give him blood, right? So if it was a simple case, a simple through and through with a little bit of musculature involvement, not much else, and we could clean out the wound, irrigate out well. We can leave it open for a delayed closure, if even that. Put them on antibiotics and they're stable, then that's a relatively easy one. They're just going to need the wound care, the ability to give the antibiotics, and the follow-up. So if we've had to give them blood, then the question is, why did we have to give them blood? Was there significant vascular involvement in it?
No, I think it was more of this is T-Tri-C. He's a trauma patient and he gets blood.
Well, yeah, but then so was he lying out there for 3 hours with venous oozing, and that's why he's down a little bit?
No. So when we got him, we saw there was quite a bit of blood on the clothes. His pulse was fast, and we just got the feeling of shock. And so we initiated probably before we got real good vital signs. But
Okay.
we've gotten hemorrhage control.
You got blood as a reflex.
Yes.
There was a bunch around. Okay.
Yep.
So then what I got to do is, at that point, going to need to evaluate the wound, right? Is it still bleeding? We're assuming at this point it's nothing that requires a tourniquet, because that's going to shift the whole the whole triage category of the patient. So let's assuming it's not. We're able to evaluate the wound. We're able to clean it out, put our pressure dressing on it. His vital signs are stable now. We're able to watch him for a number of hours. There's no continued bleeding. Then if we get to that point, now I'm back to sort of that original decision of, so he's going to need some antibiotics for a couple days that he can be given by mouth. So do we have those? Is there somebody with him that can give those to him? He's going to need to have the wound evaluated again, another 24 hours, 48 hours or so, depending on what it looks like at that point. So is that going to be back to me, or is there a local medical system or provider that can do that? It's going to be the same signs of infection, right? So is there increased pain? Is there increased drainage? Are you starting to get a fever, feel warm, starting to get lightheaded, starting to have a rapid pulse, any of those things? Then going to need to see you back sooner. Certainly a sudden return increase in bleeding. He's going to need to come back. So we're going to be going through all those. Pain control. What do we need for pain control at this point? So deciding on what's appropriate for pain control. And then I would still put in set up a set follow-up, probably in 48 hours with me if I don't know that there's someplace he can definitely be seen in 48 hours someplace else.
Okay. Yeah, like I said, I think we do a lot of things by reflex, and sometimes it's the right thing, and sometimes it's not the right thing. But that's kind of the thing with T-Tri-C is you got to do it fast. So sometimes you kind of overshoot, which can be good or bad, right?
And I mean, it's that's not wrong. Is the initial response, right? If there's any question, So when you said he got blood, I would guess he actually probably got a tourniquet put on too.
Yes,
and that's where, or you get a tourniquet put on by whoever initially saw him.
Mm-hmm.
So now it's gotten to you or me, and now that's when we have to go through that subsequent reevaluation. Can we take down the tourniquet? Is there still bleeding? Evaluate the wound, clean the wound, stabilize it, and go through all that. And by all means, I don't think there's anything wrong with the first providers doing all that. But that, as soon as that happens, that then makes me think, okay, well, I have to look a little deeper. Why was the blood given? Because I want it was given as reflex to be the last answer that comes to my mind.
Mm-hmm.
I think that's not a bad reason to do it. But first, I want to make sure that he didn't have blood spurting out, and that's why he was giving blood.
Yeah, of course. And I think that's something that, we just got to add into our thing, into our kind of repertoire or our assessment is it's okay to reduce a tourniquet for a second to find out if this is actually bleeding or not, if this level of hemorrhage control is appropriate. Vessel ligation is definitely within our skill set. So, you're definitely gonna want to get a good look at the wound before you really proceed with making a decision of, hey, this guy is gonna stay here for the duration under my care and sucking up my resources and my time when he didn't have to at all.
Right. Yeah. Exactly. And particularly because now we have something else we have to move on to.
Right. So we have I think that was good. I think that was a softball question though for you.
Until you throw in the blood. It feels like we're running a PFC case, and we're forcing the blood. So the question is, why are you forcing me to give the blood? There's got to be something underlying in here.
Right. Oh, yeah. But this one's going to be a little bit more difficult. So we have a young man also come in, and he has scald burns from boiling water over his lower arms, lower portion of his arms. They are blistering, so at least we know for certain it's at least a 2nd-degree burn. I would suspect, considering all the dirt and all the other junk that's on the wound, there's probably a few spots of 3rd degree, just making a guess. But definitely 2nd-degree burns. We've controlled the airway, we've controlled his pain, we've done some basic wound management as far as getting them covered, getting him under control, and we know that he is at least stable. We've been giving him IV fluids, and we've been getting, appropriate urine output. So, he's stable, but, again, like this, burn patients can last months. So we need to have a plan for him to go elsewhere to get that level of care. So I guess how would you first initially set him up, because we've been giving him IV fluids? How would you transition him to trying to do oral fluids? So then it would be much easier to hand him off to somebody else.
The nice thing is at least you made it a little bit of a softball, because he wasn't a pediatric and he wasn't a geriatric.
Right.
So that helps out a little bit.
You're welcome.
And from the from the description, it sounds like we're maybe talking about maybe 10% body surface area burns from the boiling water. So we've got sort of first world criteria of who's going to need to be hospitalized and who's going to need to be referred to a burn center. And even look at the CPGs. I mean, they kick in with the IV. That will need IV resuscitation at 20% or higher. So the good news is that with the IV fluid at this point, we've probably fully resuscitated them, because you can up to 20% in third world countries. Even in a healthy person, up to 30%, you can get away with oral hydration for it. So the IV is good. We've got them. We've got them fully resuscitated with 10% body surface area burns here. So at this point, I'm just going to switch him over to orals and see how he does.
Right.
He may need some Zofran, some anti-nausea medicine, so he can continue to take orals. So I'm going to want to see that he can do that over a couple hours. He's able to hold those down and continues to make the urine, like we talked about. The pain, we are going to need to give the pain control, certainly with the partial thickness burns. He's going to need pain control, and yeah, we know that's, depending on how much of this there is, that's going to be 2 to 3 weeks before that's fully healed. The wounds themselves are going to need to be treated. So I'm going to need to debride the raggedy blisters that are there, put some dressings on there. Which ones will depend on what I have available. If I had silver impregnated gauze, that would be awesome in this case, because I know those can be left in place for 5 to 7 days while he's off getting his other care. Other ones are going to need regular dressings are going to need more often. But so we're going to we need the wound care, we need the pain control. Can he hydrate? Can he eat at home? And then where are we going to be able to send them? So is there a medical system we can send them to? I mean, as you know, and I'm sure a lot of the other folks know, like in Afghanistan, you would see these, and there was no medical system to send them to, so they would have to come back to you, and you'd teach the family and them what to look for again for the signs of infection, and then have them come back every day or every couple days for the initial dressing changes.
Mm-hmm. Yep.
For the if there's full thickness, if it's boiling water, it's probably mostly partial thickness, and not hopefully that much full thickness. If it was something like they spilled a pot of boiling oil or something on them, or was on was there for a while, then you could definitely have some deeper burns, and that would be more of an issue, because those we know are going to need even longer care. And if there's any full thickness stuff, that's probably going to need skin grafting.
Right.
Almost all cases. So that's going to complicate where we send them. Now with those kids, if those, say there was a bunch of full thickness burns, still going to have to send him likely to whatever local medical system there is, even if that's some distance away, because at that point, that's somebody that is going to need more intensive care. In the U.S., that they would, the U.S., if you get 2% full thickness burns, you're typically going to get hospitalized. May not be able to do that in a third world country, but we know they're going to need long-term and more intensive care. So they're going to need to get sent into their medical system. And the fact that they can't provide the same first world level of care as a Western hospital, if it's the best that's available in the country, that's still the best we're going to be able to do for that patient. I'm unlikely to be able to do much better than what their system can do with the limited amount of supplies, time, and availability that I'm going to have based on our mission set.
Right. No, I think that's a real good point as well, especially when we're talking about handing off to local facilities, things like that. Sure, if you're talking like malaria and cholera, they deal with that all the time. They're probably experts at it. But when we're talking about generally anything else, we always think of it as it's like downgrading care, and you kind of like omnis dominus, like good luck, pal, and you go on your way. But I mean, if you really think about it, like if you're just your plan for this patient was, I'm gonna sit here and do dressing changes every day or two. I'm gonna give him bumps of pain medication and make sure he stays hydrated. Well, anybody can do that. It doesn't take, a skilled medical provider to follow instructions, right? So I would just caution people to, not necessarily be super afraid or, really apprehensive about handing somebody laterally.
Yeah, and certainly within the U.S., that's one of the, that's honestly a question that always comes up is, so if I'm working on a rescue team as a physician and I get a patient and then the ambulance that shows up has an EMT on it, don't I need to go with them because I'm a physician? I can't hand them over to a lower level of care. Well, actually, if you're handing them to a EMS or medical system, that is pretty much always accepted as a higher level of care than an individual provider with no supplies or place to work out of. So at that point, really the question that comes up is, do you have a unique skill that may be required during the transfer of that patient to the end medical facility that could make a difference? Mm-hmm. So if I have somebody that has a pending airway issue and they get turned over to a wilderness first responder that doesn't have any airway equipment, then yeah, I may need to go with them. If I have somebody that has several short bone fractures from a trauma, then handing them over to an EMT where there's no special skill that I can provide is actually transferring him to a higher level of care, which is what the EMS system in general is considered.
Right.
So, yeah, people shouldn't be afraid of, if I'm transferring him from a physician to an EMT, most of the time that's actually just fine, and that actually is handing them over to a higher level of care because it's a medical system that you're handing it to. Now, in the third world, obviously, that gets a little bit trickier, but you're still handing over to a system, and if that system is the best that's available to every individual in that country, then that's sort of the new standard of care that you have to deal with. I mean, ethically, that can be a little challenging, but that may be the best you can do for that individual.
Right. It has nothing to do with how well you know the Krebs cycle. It has everything to do with what's the capability of.
Yeah, an individual certification isn't really what, in a lot of cases, says that you're transferring to a higher level of care or not. Right. A physician with no equipment is far less capable than an 18 Delta with a bunch of equipment.
Yeah.
It's not your certification. It's what your particular skill set is in that situation that really determines whether you're handing laterally or higher or lower.
Right. Right. Is there anything else that we didn't touch on that you think would be a good idea?
No, I think I just for my dispositions,